Good afternoon or evening, depending on where you are. My name is Amish Doshi, and I am the Partnerships Coordinator for the South Asian Public Health Association, also known as SAPHA. We're very excited to have you here today to join us for our virtual fireside chat, as we will be talking about understanding and building capacity to address mental health in South Asian communities. Some housekeeping items before we get started. This session is being recorded, and so we ask that as you enter, please mute yourself during the conversation. If you have a question, we ask that you put it in the chat box, and a SAPHA board member or moderator will be sure to get to it after the conversation. For those of you that may not have heard about us, South Asian Public Health Association, or SAPHA, is the leading voice on public health issues impacting South Asians in the United States. Since its inception in 1999, SAPHA has dedicated itself to promoting health equity and the well-being of our broad and diverse South Asian American communities through research, education, advocacy, communication, and partnerships. We aim to address the unique challenges facing South Asians and advance opportunities for people to reach their utmost potential health. In short, our primary goal is to really connect people, ideas, and resources to advance the health of South Asian Americans. I wanted to take some time to introduce our board of directors, some of whom are on the call today. We have an executive committee along with 5 additional committees that are led by 2 co-chairs, as you see in the pictures here. The 5 committees that we have are research, communications, development and sustainability, event planning and professional development, and advocacy. Our committees work both independently and collaboratively with support from the executive committee to produce a wide range of products, including today's event, that you may hear about through following us on social media or from our monthly newsletters. Along with the co-chairs, these committees also include members or committee members that help support the work. And we'll talk a little bit more about how you can get involved as a committee member at the end of our time today. So as far as our most recent achievements and current projects that we have going at SAPHA, we are proud to be celebrating 25 years of SAPHA this year. And with that anniversary, we launched our Spotlight series podcasts, episodes of which can be found on Spotify and YouTube. In addition, we send out monthly newsletters highlighting all of our activities and upcoming events. Additional recent achievements include participating in the Cambridge Health Alliance Climate Health Organizing Fellows Program, hosting a recent town hall with our partners at Our Health research team on cardiovascular health earlier this year in February, which you can also find on our YouTube channel. Our advocacy committee also hosted a workshop at the recent API Gender-Based Violence Summit last month. Additionally, our board has been working on a health disparities report, which is led by our research team, which will be released at the end of this year. Our research team is also developing a South Asian research article repository, which will be available on our website soon, and are also working on developing a Caring for a South Asian patient guide. Lastly, we're happy to note that we just found out that our proposal for the National Council of Asian Pacific Americans, or NCAPA, racial equity grant will be funded, and we will be focusing on empowering South Asian communities by combating health misinformation and promoting equity through information literacy. Our event tonight will be moderated by our SAPHA President, Samira Khan. In addition to being the president of SAPHA, Samira serves as the Assistant Director of Research and Clinical Initiatives in the Division of Pulmonary, Critical Care, and Sleep Medicine at Mount Sinai. And our featured speaker for today's event is Dr. Atul Nakhasi, the Director of Science and Policy for the Office of the U.S. Surgeon General. With that, I will pass it over to Samira to take us over. Before that, just as a reminder, please mute yourself. If you have any questions, put any questions in the chat box, and then a SAPHA member at the end will be sure to ask your questions for our esteemed speakers today. So with that, I'll transition over to Samira and Dr. Nakhasi.
Thank you. So welcome everyone to our discussion today. We're very excited to have a lot of meaningful conversations and really just get through some of the big questions that we've had over the past few years on how to advocate for South Asian mental health. And so we're very excited to have Dr. Nakhasi here today with us. He, as you know, is the Director of Science and Policy for the Office of the U.S. Surgeon General and a practicing primary care physician. He has been instrumental in shaping the office's priorities, particularly in addressing mental health challenges. So, Dr. Nakhasi, would you be able to start by just sharing a bit about your background and your role in the Office of the Surgeon General?
Yeah, happy to. First of all, thank you, Samira and Safa and Amish and all those here today from the board and all members of the organization. We're very heartwarmed to be here in conversation with you all. So thank you for the invitation and congratulations on the quarter century mark as well from 1999 till now and the continued great work you all do on behalf of the South Asian community and advancing and promoting public health. So just wanted to acknowledge you and your efforts here today.
Thank you.
Just a little bit background of me. I grew up in an Indian household and family. My dad immigrated from northern India in the 70s. And then he went back and married my mom and brought her together to the state of Iowa in the 80s. And so I grew up around cows and cornfields. South Asians are everywhere, including in Iowa, as we know. And so spent most of my childhood there, grew up there, went to university 90 minutes away from home, close by, and then did my medical and policy training on the East Coast and my residency in primary care on the West Coast, where I am now living in Los Angeles and go between DC and Los Angeles. My clinic's in Los Angeles, and then the Surgeon General's office is, of course, in Washington, DC. So I currently serve as the Director of Science and Policy for the last 2 years since 2022 for Dr. Vivek Murthy, our U.S. Surgeon General. In that role, I really oversee all the scientific priorities of the office. So I oversee the development of all our advisories and all our reports. We've had advisories and reports on loneliness and isolation, on youth and mental health, on social media, on the well-being of parents as some examples. And I also oversee our policy priorities for the office as well. So that's nutshell in brief.
That's wonderful. And it's really true that South Asians are just, I think, all over. I feel like every town I've ever been to, there's at least one Indian restaurant that you can go eat at. So it's wonderful to hear that, that, you grew up in that Midwest area. And I think it's also true that a lot of us, even though we are spread out across the country, have a lot of similar health issues and, tied back to our families and our, essentially our ancestry. And mental health has been something that really hasn't been as talked about. And so just to set the stage for today's conversation, would you be able to provide an overview of the specific mental health status and landscape of South Asian communities in the US? And then additionally, would you be able to highlight just the social, structural, and cultural determinants that might influence care-seeking behaviors in South Asian communities, specifically around mental health, and why they might not, really seek out that care and the stigma that's involved with it?
Yeah, it's a great question, Samir. I'll answer both of those questions, both the landscape and then also some of the barriers to care. I think on the landscape, we have more work to be done, particularly around disaggregation of data specific to the South Asian subcontinent and populations. And so I think that continues to be one challenge and a very important research and data priority. I'll give an example. If you look at the uninsurance rate or the lack of health insurance in the United States, on average, it's about 9%. For the Asian American community as a whole, it's about 6%. But if you zoom in and you look at the Nepalese community as an example, it's 11%. It's actually higher than the US average, although the Asian American community as a whole is lower. And then if you zoom in further to 65 and older in the Nepalese community, it goes up to 15% on insurance rate, lack of insurance. So I think it speaks to the point of the very important nature of disaggregating the data. We're not a monolithic population, right? As we know, we have lots of languages, lots of cultures, lots of religions in the geographic area of the South Asian subcontinent. I'm always in awe. My dad speaks Urdu, Punjabi, Kashmiri, Hindi, and English. And so I think even just to India, there's 120 major languages. And so there's just a huge cultural diversity that I think is really important when we think about the landscape of mental health in the South Asian community. So one, I want to just acknowledge that and the very important nature of disaggregating data. Nonetheless, we do have surveys about the Asian American community abroad. So the U.S. Health Department has a survey that goes out through SAMHSA. About 70,000 individuals respond annually. The results for 2023 were just published a couple months ago this summer. What did we find from that report? So if you look at the Asian American community in general, you do see in the positive news in terms of mental health landscape, lower rates of alcohol use relative to other race and ethnicity groups, lower rates of marijuana use, lower rates of substance use disorder, lower rates of illicit drug use. You see lower rates of depression, major depressive episodes. You also see lower rates of suicidal ideation. So in one news, you have good indicators there that there improvements or progress there for the Asian American community relative to other race and ethnicities. But what else do you see? If you dig deeper into the data, you also see another really important signal. And that data is for anyone with any mental illness in the last year, their rates of receiving treatment. And in that marker, that data signal, the Asian American community has the least amount of access of receiving treatment. So about 2/3 of the Asian American community in that survey have responded that they did not receive treatment for their mental illness in the last year. And that was the highest rate amongst all race and ethnicities, 2/3 that did not. So I think that speaks to then your second question, why is that? If we have, we're seeing general improvements relative to other groups and a lot of measures of substance use and mental health. But when it comes to accessing treatment for those who do have mental illness, why is that a significant barrier for the Asian American community? And I think there are a few reasons. One area has been the linguistic aspects of making sure we're meeting people in the languages they prefer. So as an example, as a primary care doctor in South Los Angeles, I have two Punjabi speaking patients. For me, it's a lifeline to have 24/7 interpretation services that I have available to help counsel on diabetes management, on high blood pressure management, on chronic disease management. So the linguistic services, particularly with the linguistic diversity of the South Asian subcontinent, is very, very important. Another is the cultural competency of the workforce, the diversity of the healthcare professionals serving that community. So that continues to be a really important aspect. We want providers that reflect the diversity of the communities they're serving. Number two, I think a third area, and this is the area our office has leaned the most into, is stigma, is really destigmatizing mental health and opening up that conversation. And you'll often see Dr. Murthy, the U.S. Surgeon General, talk openly about the importance of asking for help, of checking in with others, and that seeking help is a sign of strength. And that, for so long, and I've seen this in my own family and in my community, about mental health has often been shrouded in shame and in stigma. And there's a lot of silent suffering. And I think that's one reason you see us having the highest rates of lack of receiving treatment out of all other race and ethnicity groups. And so that's really an area our office and Dr. Murthy and our team has really leaned into, is how do we open up that conversation? How do we make it okay to ask for help? How do we overcome barriers to access to culturally competent care in communities where we're meeting patients where they're at? So that's kind of the high level of what's the current landscape say. Certainly more data is needed to disaggregate, and what are some of the barriers and how we can overcome them.
Yeah, it's really helpful to, just hear that the Office of the Surgeon General is putting such high priority on this because, as you've mentioned, the stigma, it makes it so hard for our communities to even talk about this and talk about the fact that they're suffering, let alone then try to seek help for it. And I think the fact that we're having conversations by South Asians on a national level helps to make it easier for people to just acknowledge that this is a problem that exists and talk about it. And, the Office of the Surgeon General has been putting out some advisories recently, both on loneliness and isolation and social media usage. Would you be able to talk more about these advisories and their specific implications for the South Asian community?
Yeah, I'd be happy to, Samira. Yeah, thank you. These have been top priority areas for us. We've really looked at mental health and asked ourselves, what are some of the key drivers that are driving mental health challenges broadly in the nation? And two drivers our office has identified and leaned into is technology and social media as a driver, and also loneliness, the epidemic of loneliness and isolation as a driver. So I'll briefly touch on both. Loneliness being the subjective feeling of lacking connection in one's life, and isolation being the objective measure of that isolation. So we know both of those factors are predictive of physical and mental health outcomes. So, for example, loneliness and isolation are related to premature mortality, comparable to smoking, to excess alcohol use, to obesity. So it's a risk factor for cardiovascular health, including heart disease and stroke. It's also a risk factor for mental health, like depression and anxiety. And there's a bidirectional relationship between loneliness and isolation and mental health. those who experience higher levels of loneliness and isolation are at higher risk for downstream mental health conditions and challenges. And those who face higher rates of mental health conditions are at higher risk themselves of experiencing loneliness and isolation downstream. So there's an important bi-directional relationship, not only a physical health relationship, but a mental health relationship that's bi-directional to loneliness and isolation. So we've really leaned into raising awareness. That's a really important factor that's been underappreciated in one's mental health. And the antidote to that is social connection and social support. And we've really leaned into that as well as the antidote to loneliness and isolation, and how social support is often one of the best buffers to both prevent the onset of mental illness, but also to help treat it by providing the support people need. So that's in kind of a nutshell, social connection and isolation and loneliness as a subject matter. In terms of technology, we've been very worried, particularly for youth mental health, the role of technology. And one example of the data that we often lean into is that young children and adolescents who spend more than 3 hours a day on social media platforms often experience double the symptoms of depression and anxiety symptoms. So we know there's a relationship there as well with the use of certain platforms, particularly with features that could be harmful, interactions and content that could be harmful for a developing brain between the ages of 10 to 19 in adolescence. So we've been very concerned also about the role of technology. The central question we're asking is really, how do we optimize the benefits of technology? We all use technology. I have two cell phones right in front of me, right? Well, a work phone and my personal phone. Like we're all embedded. We're having this conversation on Zoom. So how do we make good use of technology, but how do we reduce the harms, particularly for mental health of young adults and adolescents? And so those have been two areas. And then just briefly to touch on how does this impact our community? I think about it very personally when it comes, for example, to loneliness and isolation. My parents immigrated from India and left their families. I often heard my mom growing up, Samira, in my own household in Waterloo, Iowa, of her loneliness and how sometimes she experienced regret of leaving her family for future opportunity. And I think that can be characteristic oftentimes of our culture. We oftentimes value education and economic opportunity and came to this country in the 60s, 70s, and 80s, many of us, not all of us, but many of us, to pursue our families' better economic opportunities and educational opportunities. My parents did too. And my mother left behind 4 brothers. She was the only daughter of her parents. She left behind both of her parents in New Delhi, India. She left behind a brother in Qatar and in New Zealand and 2 in India. And she came to the United States. And I remember her grappling deeply with that loneliness in the United States. And even now, I'm in Los Angeles as her son. My sister is in Dallas and my brother is in New York. And we're again away from home. We pursued higher education and we pursued career opportunities. So I think it's very personal. Many of us have opportunities that have taken us away geographically from our communities or from our family members. And that weighs on me personally. I always think about how am I there to provide support for my aging and elderly parents. So I think this is a very relevant issue to the South Asian community, has been for me and my family personally. And it's helped me reconsider how I'm providing the best social support I can to my family members, my siblings, and to my parents.
Yeah, I mean, your story, I think, is just something that everyone can probably relate to. I'm sure all of us have either parents or grandparents that have left behind their home countries to immigrate here for a better life. And, central to a lot of South Asian culture is that essence of community. And so you often have, aunties getting together and sharing their pains with each other. And yes, amongst the gossiping and the teas, you have them spill out their, the problems and their issues. And so often they feel lighter after having that conversation. It would consider really in today's terms might be group therapy, but we don't use those terminology, especially not in our communities. And so then they immigrate here and you talk about, isolation. And I think that's something that's very apparent, especially as people spread out across the country. The pandemic did not help that at all. Especially when people had to stay at home. Oftentimes we came here and we created religious institutions as our community centers, or other cultural festivals would become centers for community. And so that isolation, I think, is definitely building, but we don't really have the terminology to address it, especially since we, mental health issues don't really manifest in the same way amongst the South Asian communities as they do in other communities. And then on top of that, you have language and other cultural barriers. And so how do we even address mental health issues when we can't find the words to talk about it? There's just so much I think that we have to build upon. And we want to talk about improving access to mental health care, but overall, how can we, what are some initiatives that we can do both as a community, as the Office of the Surgeon General, as SAPHA, to really just effectively build that capacity to talk about mental health, but then also to eventually improve access to mental health care for our community?
Yeah, Samir, it's such a good point. And just to build on your point and then answer the question too, that community building is so important. It's so important for one's mental health and one's sense of social support and psychological and mental health support. I think even back to my upbringing and roots in Iowa, we had 50 Indian families in Northeast Iowa. We actually had a Northeast Iowa Indian Association. And that was the lifeblood of our cultural community to maintain that sense of connection, that sense of support. And just like you said, we may not be the best at seeking formal treatment. And there's a lot of complex reasons and barriers that we can get to for that, as we highlighted already. But we do lean on each other in informal ways of helping and informal ways of support and through our cultural networks and religious networks. And so that was a part of my upbringing and the support my parents saw from the other community members, South Asian community members in Waterloo, Iowa. And I think rebuilding that is a very important work for this nation, not only for our community, but in general, the sense of loneliness and isolation we're seeing across this country and the decline of civic institutions, of volunteer institutions, of religious and cultural institutions over decades. That's happened in the United States. So one, I just want to emphasize that point and our role in helping build that community. I remember always my mom would drive 50 minutes to the local Indian grocery store in Cedar Rapids, Iowa, and it would be a highlight because she had this sense of cultural connection that came back between food and the local store owner there. And so those moments of how do we make it easier to build, we call it in our office, social infrastructure, which are the places, programs, and policies that help bring people together. So that's really been an area we've been trying to help spur further investment and community building around. And then to go to your question just on initiatives, there's a tremendous amount of work. As many on this call may know, the president signed an executive order early in his term in May of 2021 to reestablish the White House Initiative on Asian Americans, Native Hawaiians, and Pacific Islanders, and also released a national strategy, the first ever in 2023, to advance safety, equity, and justice and opportunities for the community. From that, 32 federal agencies have put together work plans and action plans on how to move the needle forward. I'll highlight just 2 or 3 examples here of some of the work that's happened from the U.S. Health Department, Health and Human Services Department in our office. So CDC has invested now more than $3 million in forging community partnerships to translate health information in more than 30 languages for the Asian American community. We also have CMS, which oversees Medicare and Medicaid, and they made it a requirement for certain insurance agents and brokers to undergo cultural competency training for brokers and agents who have health insurance plans on the exchanges. CMS has also done translation for their Medicare information, so elderly members of our community can have that in ways that are linguistically compatible to their language preferences. We've also seen HRSA actually increase the primary care loan forgiveness by 50% from $50,000 to $75,000 to practice for 2 years for healthcare professionals in high need areas. So that was just announced earlier this year as well to incentivize the capacity building that is so critical. I'm a primary care doctor. I care for most of the mental health of my patients.
Right.
And the primary care setting is first point access. So that primary care robust pipeline of capacities is so critical. And then SAMHSA has started to disaggregate race and ethnicity data in its national yearly survey that I just highlighted up top too. So continuing to understand the specific needs of the specific diverse populations is really important. So there's a whole host of activities ongoing in federal government. And then maybe the last one I'd highlight that needs more and more awareness is 988. The crisis line that the national government helped support just a couple of years ago. There were a lot of local hotlines, right, for mental health crisis and acute care across the country. But now there's a universal number. The awareness is not the same as 911 yet. And so we have really leaned into helping support that initiative as an office and could use everyone's help on how we're ensuring 988 is a resource for our community. If we have friends, if we have family members, if we have community members who are suffering, who are showing signs or symptoms of mental health distress or acute crisis care needs, that we make sure we're helping them link them to needed care. And so 988 actually offers more than 240 languages in support for interpretation services for that acute crisis care and is available 24/7. So that's also been a big initiative, is helping promote that. So there's awareness that you can get care in a moment's need, in moments of crisis, in a way that's linguistically compatible to your preferences as well. So those are just to highlight a few of the initiatives and work that's ongoing in the federal government.
It's really helpful to know that there is so much happening. And I think one of the biggest issues is that like there's stuff that's happening at the government level. And then, we as nonprofits end up, getting some of that, or we understand what's happening. But how do we then take what the Office of the Surgeon General is doing and disseminate it to the South Asian communities? People who maybe are not as aware of these initiatives and these programs that are happening. And how can organizations like SAPHA be that bridge and help to contribute to building that capacity so that you do have South Asians engaging in mental health care, accessing it, also on the other end being providers and disseminating some of those resources to the community?
Yeah, it's a great question, Samir. I'll give a very specific example of a successful program that I often look to as a model for many of us to try to replicate. So I had a good friend, a South Asian physician friend who participated in this program in the Chicago area and brought my awareness to it. But it was the Black Barbershop Health Outreach Program. And in that program, they embedded healthcare professionals within Black barbershops to reduce healthcare disparities amongst Black men, specifically diabetes and high blood pressure. The reason I'm highlighting that program is there was actually a randomized control trial published in New England Journal in 2018 on the program. What they did is they randomized barbershops to either a control group where a lifestyle advice was given by the barbers to the community members who were there, and encouragement for lifestyle modification and encouragement to set up a doctor's appointment. That was the control group. The randomized intervention barbershops had a clinical pharmacist embedded within the barbershop to provide screening for high blood pressure and medication treatment to help treat in a setting that the community members were already in the barbershops. What did they find from the results? The control group dropped by about 10 points. Their systolic blood pressure, there was an improvement. The intervention group, Samira, saw a 30-point improvement in their systolic blood pressure, high blood pressure, which is a silent killer and one of the most common risk factors for heart disease. And we know there's a disproportionate impact to heart disease in the South Asian community as an example. And we know there's links between depression and heart disease as well. So that's one example. What can we take away for organizations like SAPHA and others from that? I think to me, that speaks to the critical importance of meeting people where they live, where they play, where they work, and where they worship. Where they live, where they play, where they work, and where they worship. That's so critical. That example to me is a form of a promising practice where they met community members where they were to close disparity gaps. I think the other key message there is like we need to work closely with trusted messengers. The Surgeon General's office may be trusted for some, and we may not be trusted for others. And that's okay. We can work together to build that trust, to work in partnership with religious leaders, spiritual leaders, civic leaders, community leaders, nonprofit leaders. How can organizations like SAPHA, like the Surgeon General's office, like community-based organizations and nonprofits work with community leaders to be able to promote public health education and preventative activities? And as an example, can we screen, instead of screening for high blood pressure, which is important, could we screen for depression and anxiety in sites of worship, whether it's the mosque or whether it's the temple or another site of religious worship, using validated questionnaires like the PHQ-9 for depression or the GAT-7 for anxiety? And then can we link to care by partnering with health systems to be able to provide that mental health care and address those mental health challenges? So I think that's just one example of like how can nonprofits and community-based organizations work together to essentially meet individuals where they are, work in partnership with trusted messengers and link to care that's needed.
Yeah, it's so important, I think, to, just really meet people where they are. And like you said, a lot of like where we work, where we play, where we pray, that's where you're going to find the bulk of our community. You're not going to have them, go out of their way to really seek some of the care, given all the, the structural barriers and the fact that people are working, and the little free time that they do have, they want to spend it with their community. And so I think bringing these programs to the community is so important, to really help ensure that we are capturing people, especially people who might not even consider themselves patients, right? Who don't have that language to identify what is mental health or what that looks like. And so having trusted community members be that gap between the community and these services is so essential. And so I think looking ahead, what would you say is your most important message or key recommendations for really addressing the mental health problem in South Asian communities, and removing some of that taboo and that stigma, and allowing us to fully build that capacity to address the problems that are underlying in the community?
Yeah, it's a great question, Samir. I think the key message our offices have often promoted is that mental health challenges are common, real, and treatable. And really acknowledging that everyone at some point in their lifespan endures a mental health challenge or struggle
Right.
in their lives. All of us at some point in our lives. And so they're very common, they're very real, and they're treatable. And I think that's been a key message that our office has often spoken about. And along with that, Samira, we can open up that conversation, and that seeking help is a sign of strength. That's the second key message our office has really leaned into, that there's been such longstanding, as you mentioned, stigma that has been really challenging. I remember, growing up in Iowa, Waterloo, Iowa, there was always a focus on good grades, on academics, on your tests, on a good career, on being stable. But not once do I recall a conversation in my household about mental health. It just wasn't acknowledged growing up, as a South Asian a boy in my household and in my community. There was oftentimes an awareness about physical health, but not mental health. And I think just understanding that mental health is health, that it's common, real, and treatable, and that seeking help and asking for help is a sign of strength. I think those are some of the key messages that we've often promoted, and just having the conversation and seeing someone who looks like you, who comes from your background, who holds your values and cultural values, opening up, role modeling that we can talk about this, that it's a sign of courage to talk about our own mental health struggles, can make a world of difference for others who may be silently suffering. And seeing examples of South Asian leaders really open up about their struggles and making it normalizing the ability to seek and find help, and that's a good thing and a sign of strength.
Yeah, it's just so important. I think the fact that we have, people like you, people like Dr. Murthy in these offices, really opening up that conversation, and being so relatable. I think it's so important to see people who look like us in these positions of power talking about these hidden issues that are in our community, to make it okay to talk about it. It's just so important. And we're so glad that you were able to, join us today to have this important conversation. And I would like to continue that conversation by just opening it up to the audience, to see if any of you have conversations or questions, sorry, for Dr. Nakhasi. And I see, Kritika, you have a question in the chat. So if you want to just unmute yourself and ask Dr. Nakhasi, that would be great.
Absolutely. Thank you so much for that excellent conversation. And I completely resonated with a lot of what you talked about with regards to, reaching out to temples or reaching out to religious places, places where our community finds a sense of safe place and community, and partnering with them. But if the organizers that actually lead these community organizations also have that stigma about mental health, how do we reach across and say, hey, I know the stigma is prevalent even within you? Or the organizers themselves, like, how do we overcome that divide in the first place?
Yeah, Gopika, thank you so much for that question, by the way. It's a great question, and it's a real one. It's a real barrier we all face and have experienced when we're trying to address this, even in our communities, even in our households. right? Like even sometimes within our aunties and uncles and our family members to address and bring up mental health, it could be a not always a acknowledged conversation or aspect of health and hard to have. I think it's tough. I think a couple things that come to my mind is one is sometimes, a lot of times I'll give an example. In my clinic, I do a lot of tobacco counseling. And so much of what I have to do is see when the patient is ready to quit. And so I do a lot of motivational interviewing. When are you ready? Like some of my patients are like, Dr. Nakhasi, no, I'm going to keep smoking. Like it's not an issue. I know there's health problems I could face, but like I've been doing this for 50 years. Like I'm not ready to have the conversation. I get that response sometimes. There are other times that are like, Dr. Nakhasi, I've tried 3 or 4 times. I really need help. Do you have anything that could help me? There's medication assistance, like a nicotine replacement that can help those quit. So part of it is understanding who's ready when, and being there to support when someone identifies a need. Like many times, it's being there readily to support and identify someone who's struggling, to then plug them in. And so that, is one kind of aspect of it, and continually checking up because you never know when they may be ready for that conversation, whether it's someone in the community or a family member when they're ready to address that conversation or have the mental health conversation. The other way, oftentimes can be to build common ground on what they already do acknowledge and care about. So the Indian community might really care about lowering blood pressure because we have disproportionate heart disease risk, or controlling their diabetes, or controlling their sodium intake, which relates to high blood pressure. So can we start and build where there's common ground, common acknowledgement, common desire to move forward? And then from that trust building, can we embed a PHQ-9 screening survey? Can we embed a GAD-7 screening survey and say, well, you know what, auntie or uncle, your blood pressure is high. We're going to make sure we help plug you into primary care. But, we also would like to survey for how your mood is or how your stress levels are. And we'd like to help, make sure that you're feeling well as well. Like, can we embed and build on meeting our patients where they are with their needs? It's another, aspect of how I often go about the care. So don't give up. Keep trying. Be there when they need you, and build on the common blocks of commonality of what they do need and what they are self-identifying as their needs, and keep the hope.
Okay, thank you.
Thank you so much.
I have Pooja next in the queue. Questions?
Hi, Dr. Nakhasi. Thank you so much for being here today, and thank you for the team at SAPHA for putting this on. I wanted to go back to the very first set of statistics that you presented to us about like the rates of, mental health and suicide and addiction and all of that in our communities. And I'm wondering, how is that data collected? And I have a follow-up based on your answer.
Yeah, it's a good question. A lot of it is in-person interviews, surveys. So it's the National Survey on Drug Use and Health, and happy to share more information on that too. And happy to share. There's a whole methodology section, so very happy to do that. And about 70,000 sample size is about 70,000 nationally representative individuals, and so that's done annually. And a lot of it, I think about the majority of it are in-person survey interviews. In terms of the methods, but happy to share more on that, and happy to take your second question too.
Yeah, so the follow-up to that, to your point about stigma, right? Our communities we don't talk about these issues. We don't acknowledge these issues. And, I guess I'm wondering that combined with the fact that this seems to be self-reported, would that suggest that the data is an underrepresentation of the actual problem, or are there ways that you guys are implementing strategies that you're implementing to get a more accurate picture of what the overall state of our community is when it comes to these topics?
Yeah, it's a great question, Pooja. I definitely think that could be a factor. At the end of the day, there is could be underreporting of this, particularly because of the history of stigma and also shame about talking about mental health within the Asian American community. And also just to emphasize that point, that data I reference is Asian American community as a whole, which is not monolithic at all. And so, right, there could be tremendous, both if we dialed into the data, we could say huge variations where some specific subgroup demographics are higher on substance use or higher on suicidal ideation, others are lower. And so one is caution on just the aggregation of the data is not representative of each individual subgroup. Two is certainly could be underreporting, and there's a social desirability bias oftentimes with surveys of trying to, of reporting what one might feel is a socially desirable report to provide. So that could certainly lead to underreporting and underestimation as well. And so I think we have to keep all these cautions in mind as well when looking at the data.
Yeah, thank you. Thank you for providing that. Because I think just for me, like from a policy perspective, a lot of policy is driven by data and using those numbers to figure out the scope of the problem and the priority communities. And I just always see the numbers on the AAPI community and I'm like, this feels wrong. But thank you for sharing that.
Yeah. And Pooja, the last thing I'll add to you, I think you're making a great point. The last thing I'll add is just because it's better doesn't mean it's zero either. So for example, the suicidal ideation data from SAMHSA that was released in this annual report that came out a few months ago for the year 2023, for white and Black populations, it was 5% suicidal ideation rates. For Hispanic population, it was 4%. For the Asian population, it was 3%. So 3% is not zero still, right? It's 3 out of 100. That's concerning still, right? Like even though it might be better, and like you said, there could be biases in how the data is self-collected because it's subjectively self-reported. But even then, 3 out of 100 people having suicidal thoughts is concerning, right? And how do we still improve, even if we have made good progress, or even if there are better rates across some measures, there still can be improvements to be made. So I think that's another caveat there is, relatively the community might be doing better on some measures, but there's also caveats in the data. And then even so, how do we continue to improve the mental health and identify those who are most at risk that the aggregated data might be not dialed into?
Thank you. I have Arnab next in the queue.
Thanks, Dr. Nakhasi, and I just can't underscore my colleagues' questions about the complexity of this matter. And I, just about the shared language that Samira was talking about. I'm a professor of public health, and so half of my mind is in the academic world. And I will underscore something that Pooja said, which is it just feels like the data is wrong, right? We live in these communities. For those of you that are into Dr. Aruna Jha did a wonderful, it's not wonderful because of the results, but suicidal ideation and suicides are vastly underreported, mainly due to racial misclassification, the metrics that we're using to actually classify as a suicide versus another cause of death. And so part of the question I have is, the other element of this is sort of this model minority mythical ascription that many of us have fallen victim to, which is we do not have these problems, right? And when Dr. Nakhasi, you talked about sort of validated instruments, but the research in me says, who were they validated for, right? And I would venture to guess that many of these screening tools are not culturally appropriate, responsive to the social context of mental health. You referenced a randomized control trial using barbershops between African Americans and whites. I can't imagine how anyone like me could do an RCT with South Asians and faith, right? So part of this is that the mechanism that we use to generate the evidence needed, we simply don't have access to. And so this is more commentary than question, but I hope that the vehicle of your office can really push that within the scope of equity mechanisms, South Asians and Asian Americans as a whole are largely excluded. If you look at something like the diversity supplement at NIH, Asian Americans and South Asians have to make a harder argument that we're. So, having you as a member of our community, Dr. Murthy, and hopefully as a president-elect who is a member of our community, how do we make sure that we also have the resources that we need to actually provide policy and programmatic recommendations? Because right now we're just pushing for anecdotes and that we know it's true because we live this reality. But then, a governor, a legislature would be like, well, how do we know it's true? That's just your story. So pardon the editorialization, but, you can see that this group of people, this is something that's near and dear to us.
Yeah, thank you so much for that, Arnab. And I couldn't agree with you more. So much, as a practicing doc, so much of the clinical research even I come into practice was not clinically diverse and representing and externally valid to be able to apply to the populations in the first place. And that is a well-known fact of clinical research in the medical and public health fields. on who those sample sizes were and how it was conducted and how applicable and pertinent that is to the populations we're trying to improve the health for, or who I might be seeing in my primary care clinic. So couldn't agree with you more. I think that it speaks to a lot of the work being done around clinically diverse samples and sample sizes and study enrollment, which is a very, very important part. There was a big effort in the clinical trials, for example, right, with the vaccines during the pandemic to ensure that was representative of clinically diverse populations in the United States. But much more work is needed to be done, particularly because, as you mentioned, many of these validated instruments or many of these treatments or interventions were done in groups that were not representative of the state of our communities currently. So I think that's very true. I think the other thing about data here is this, it's really, really important. US Census now, if you look at their data, they do disaggregate very specifically by many, more than 24 demographic groups within the Asian American community. Much of our mental health data is not disaggregated to that level and that degree. And we know we're not a monolithic community, right? As I shared above. And so I think that's a disservice to be able to provide to just even know the size and scope of the challenge, and also who's at risk. And to overcome the stereotypes about the community as well. And so I think, and even the data I highlighted up top, that like even amongst all groups, we have who are least likely to receive treatment. So I think all those are right. I think there are efforts across SAMHSA, HHS, CDC, and those who have measurement instruments to ensure that health equity is a very core part of the lens. And how they're assessing the landscape of public health, though, but much more efforts are needed.
Thank you. I think we have time for one more question. We have Sumita. You had a question in the chat if you wanted to ask it.
Yes, hi, thank you. I just was addressing it in the chat, but I find that there is a general sense that mental health treatment and access to mental health services are really viewed in our community as a response to a crisis rather than something that, at least, we work a lot in our community organization with youth. And the way that I try and sort of conceive of it is this is one of those foundational tools. And I really appreciated your comments about how when you were growing up, really, this wasn't a topic of conversation at the dinner table, mental health. But how can we really change that perception of mental health? Like, that this is a situation that gets addressed when things really have gotten to that point where we don't know who else to turn to. Now let's go and see if we can find a provider that is South Asian and, because we're at our wits' end, rather than an early intervention that really, particularly for our youth, can be something that if we have a positive association with the mental health treatment access, then when they're out of our homes and, our kids are trying to figure out how to deal with a stressful situation down the line, they know that they can turn to a provider. Obviously, I think much needs to be done to make sure that the provider population is reflective of of the community that it serves. And I appreciate that point as well. But, do you have any thoughts around really changing that perception of crisis response, pathological response, rather than something that can be viewed as a foundational mental well-being a tool of resilience for us?
Yeah, so it's a great question, Samita. I think a few thoughts to reflect on. I think you're completely right. Like prevention is the best treatment. Oftentimes I'll say that. And we also know that the absence of disease does not equate to good health. Just because there's absence of disease doesn't mean that's good health. We want, to support and promote positive, for example, social support or social connection as a buffer and as a preventative way to downstream, for example, mental health conditions. So I think that's right. Like there needs to be a focus. The treatments are critical, but we also need an upstream focus on prevention. And not just that the absence of disease is the optimal state, but that we can promote healthy mental health. And then I think the other aspects of this question, I often tell my patients too, I often say it's a lot easier to lose 5 pounds than 50 pounds, right? Like if we get upstream, if we get early, we can intervene and end up with better health outcomes with early intervention as well. So I think a few things here are really important. One is the linkage to health systems and community clinics to be able to provide that care. But I think one of the challenges too is there's just such a shortage oftentimes we're seeing, right, of provider networks, particularly culturally competent networks and communities that our families, our parents, our neighbors, our South Asian community members can feel comfortable with, comfortable and confident. There needs to be some sense of psychological safety and trust to open up about stigmatized topics. And whether it's sexual health, whether it's pregnancy, whether it's substance use, whether it's mental health, I encounter this all the time in my clinic. Sometimes it takes me multiple years to build trust with a patient to get them to open up about a conversation that's really sensitive, that not even their spouse is aware of, not even their most intimate family members are aware of, because the topic is shrouded, unfortunately and tragically, in so much stigma and so much shame. And so I think one is that trust building is very, very important. But the other thing is, there's the professional capacity of the clinician and the healthcare professional, but we all have personal capacity to check on each other too. So one thing our office has done is really help promote peer-to-peer support and peer-to-peer programs. Oftentimes, and this is more specific to youth, but I think it could apply to the adult population too. We see many times youth, the first people they turn to for their mental illness and their mental struggles are each other. It's not mom and dad. It can be the teacher many times and the school professionals, but most times it tends to be each other, their friends, and peer to peer. And so that part of me is also, we have our professional hats, but we also have our personal hats. And so one thing I often think about and our office encourages is, how are we checking on each other? How are we checking up on mom, dad, on brother, sibling, on coworker, on colleague, on neighbor, on friend? Because there is a tremendous sense of personal agency too, where we can check up on each other and make the time to see how someone's doing, and also watch out for signs and symptoms of concern. Is someone's mood change? Is their sleep changing? Is their appetite changing? Is their behavior changing? Is their demeanor changing? Their affect? How can we all be more aware of how people are doing? Many times those signs are invisible. We're not seeing them, but how are we both aware of those? And how are we checking up on people? And then how are we encouraging them to seek professional care if it's needed? As well. And so I think part of us also wear that personal hat, and how can we help support the professional capacity? Because even in my case, right, it's 7 years by the time, 4 years of med school, 3 years of primary care training. We have a mental health crisis today. We can't wait 7 years to make sure there's a robust workforce of primary care doctors, or shorter durations for different professionals, or longer durations for different professionals. So our office has also leaned heavily into what are robust, scalable, promising peer-to-peer models? Because oftentimes people turn to their peers first before professionals, and we can all play a role in that.
Great. Thank you, Dr. Nakhasi. I think that's all we have for questions for tonight. So I'm just going to turn it back over to Amish to wrap it up for us.
Thank you, Samira. So as we close out, just a couple of things we want to share with you all. We have quite a few events lined up for the remainder of the year. Tomorrow, our Climate Health Task Force lead, Thoin Begum, will be participating in the AAPI Climate Justice Panel. You can register at the link on the slide. In 2 weeks, SAPHA will be hosting another event on September 27th, which will be a panel discussion on suicide prevention and awareness. You can also register at the link on the slide. We will also, if you're following us on social media, you'll also see the registration links go out as well. And then I also want to talk about one of our partnerships. SAPHA is supporting the data collection efforts for CARE, or Collaborative Approach for Asian Americans, Native Hawaiians, and Pacific Islanders Research and Education, which is an NIH-funded voluntary research study. The goal is to create a large repository of people of Asian American, Native Hawaiian, and Pacific Islander descent who can be contacted about Alzheimer's disease and related dementias, aging, caregiver-related research, and other health topics across the lifespan. This research is being performed by UCSF, UCD, UCI, and a number of other CSU East Bay, as well, and other institutions and organizations with IRB approvals for research with Asian Americans, Native Hawaiian, and Pacific Islander populations. All the collected information is going to be de-identified, and your participation is voluntary. Our SAPHA is eager to help support this important data collection effort, which will help contribute to meaningful research on aging-related diseases and health in A and HPI communities. And to participate, we will share the link that we have provided, which allows you to sign up to be part of the registry. We also have an advocacy workshop coming up in October, and we'll stay tuned for more information from our social media channels and our newsletter. And lastly, we will be also hosting our annual in-person event known as Chai Chat at the American Public Health Association conference on October 27th in Minneapolis. So we're looking forward to seeing many of you there. As we mentioned earlier, you can get involved in our organization by signing up to be a committee member. We have a QR code on the screen to help complete the form, or you can head over to our website and find a link to the form from our contact page. Additionally, if you are interested in partnering with us, we also have a new partnership request form, which can also be found on our contact page on the website. Finally, be sure to follow us on our social media channels and to sign up for our newsletter. These are the different links. We have our website, we have Twitter, Facebook, LinkedIn, Instagram, and of course our YouTube channel where the recording of this amazing conversation will be posted. Thank you again to Dr. Atul Nakhasi for everything you've shared with us today. We really appreciate your time. And with that, we are going to sign off for the end of the chat today. So thank you very much for attending, and we'll be sure to send out the recording, and it will be posted on our YouTube channel as well. Thank you so much.
Thank you everyone for attending.